Hello, check, check. Hello, 1, 2. Hello.
Hello.
Welcome you all for the first meeting of Integrated Balance Forum. Uh, so I would like to invite Dr. Srinivas Dorasala to start the session with his first lecture. Thank you.
Live streaming started.
Yes, sir.
So thank you all. Thank you for coming. So we'll start the day. First thing we are going to deal with is it's about 1 hour. What's the time now?
9.
आधा घंटा late.
Not late.
So we'll start from 9 to 10 or
Yes, sir,
9:30 को complete करना है.
No, 9 to 10. You take your time.
Okay. So we are going to cover the in the clinic before any instrumental evaluation, whatever is happening. The person with vertigo comes, vertigo or balance related complaints, whatever a person comes, how we can approach and how we can reach a conclusion. And a lot of time this conclusion is possible. What would actually be problematic is that we don't know the condition or this thing. Most of the time the patient is shouting the condition in the face if we if we talk enough to the patient. So once we know the condition, matching and getting the diagnosis is quite easy. The approach that I take is what I am going to present to you right now. So it's going to be a little bit flexible approach, so that is why based on what the patient does. So now, typically, the first 3 to 4 minutes or even 5 minutes, we should allow the patient to talk in the history tape. Okay, we should not straight away tell क्या होता है, आप घूमते हो, दुनिया घूमता है, all these things and all. We should just stop and just allow the person to talk. Only interruption, the only time I will talk, I will make an interruption of the patient and stop the patient is when the patient takes another course which is a non-fruitful course, which is सर मैं थक चुका हूँ, मैं वहाँ गया, ये डॉक्टर मैं अपोलो में दिखाया, मैं मेदांता में दिखाया, मैं when they start taking like this and ये भी हुआ वो भी हुआ, that is fruitless for me, because where all you showed is not important for me, okay, and how many investigations I have undergone is not important, but as long as the patient is telling their complaints, whatever description of the complaint, I will allow them to talk uninterrupted, because the diagnosis lies there. For it is for us to pick up the pattern and make the diagnosis. Now once you do this, what are the things that I am looking for? The most important or the first point that I am looking for in a patient is this description episodic or is this description chronic? Which is a very important point. This description episodic लग रहा है कि chronic लग रहा है. So that is very very important in the diagnosis, because there is no better clearer separation of diagnosis based on a description than this one. Chronic has a totally different set of diagnosis. Episodic has a totally different set of differential diagnosis. So if it turns out, so what is episodic, what is chronic, we need to know. Episodic is when the person gets the suffering, very bad, but in between, patient is perfect, okay. A few episodic conditions eventually may become chronic. Those conditions also we will come to later. But in the beginning of the course, was it episodic or was it chronic? So if the person today, if the description looks like chronic, sir, har roz hai, then the next question that I am going to do is, कितने सालों से, from how many years it is there? Sir, 10 साल से, 5 साल से. In the beginning, was it episodic, or it is from the starting only it was chronic? In the beginning, if it was episodic, then I will classify this condition under episodic and evaluate it as an episodic, and I will go by the symptoms that were there in the virginal or original phase. Okay, virginal phase or original phase is when it was not modified by any drugs, any long term, because a lot of people are taking 3, 4, 5 drugs. So So what happens is, one drug tries to reduce the symptom 10%, introduces another 20% of new symptoms. That new symptom 20% is not understood, and then that what happens is, somebody else to treat the new symptoms adds one more drug. Like that, 4 or 5 drugs are there already on the patient, and lot of time asking the patient to stop all the drugs with all encouragement for 1 month, and then coming back would have taken care of most of the symptoms, and there would be 1 or 2 symptoms to 1 or 2 small complaints to take care of. So that is one more important tip that we use. Coming to episodic, now once you have determined it is episodic, next question would be, you can take it either way. You can take it as duration, or we can take it as what is the trigger. So the most important thing is a trigger है क्या इसका? Means episodic तो है, but triggered episodic or spontaneous episodic. This is an important point. So triggered episodic is like, sir, I get it when I bend, I get it when I roll in bed, when I turn in bed, like this. This is triggered episodic. Then there is the spontaneous episodic. अचानक आ जाता है. I am a teacher, I am taking class, suddenly I feel like I will push. This is अचानक से आता है. This is the thing. Now we will first deal with the differential diagnosis of this thing, non-triggered or spontaneous episodic. If it is non-triggered and spontaneous episodic, we need to again redefine non-triggered. There is no true non-triggered in vertigo. There is no true non-triggered in vertigo. There is always a trigger for vertigo. But the true non-triggered, so here when I say non-triggered, it means no immediate trigger. मैं ये करते ही ये आता है. That is not there. Okay. So curvet, when I turn in bed, the moment I turn in bed, I am going to get is immediate trigger. So when I'm talking about spontaneous, there is really no completely spontaneous vertigo diagnosis. So most of them have a trigger. For example, when I'm stressed out, I get it. Stress is a trigger, but I'm not like, now I feel something and then I get it. It's not like that. So that is why you have to differentiate. This is spontaneous. Now once it is a spontaneous episodic vertigo, now the timing becomes important. Here we have 2 different tools. Extremely short lasting vertigo, half second, split second, 2. Vertigo that lasts for few seconds, okay, maximum 1 minute, okay, that goes off. Here the differential diagnosis, from here only you can start making. If there is this kind of a vertigo in a 3-year-old, 4-year-old, 5-year-old, 6-year-old child, the diagnosis here only you know a new diagnosis, that is benign paroxysmal vertigo of childhood, BPVC. What is the caution here? It sounds like BPPV.
It's a variant of migraine.
Yeah, it sounds like BPPV. Okay, सुनने में BPPV जैसा लगता है. Our brains are very good at pattern recognition and then trying to push things and make life easy for us. In that, they make mistakes. BPPV jaisa, okay, the word sounds like BPPV, therefore you start thinking, BPPV positional. Positional nahi. This is a migraine precursor. It is completely spontaneous, beautifully responsive to any anti-migraine agent of your choice. And that age group, whatever is your anti-migraine agent, it will work. Okay. So this is BPVC, benign paroxysmal vertigo of childhood. So we saw the first differential diagnosis. Where did this come from? This comes from where we started off by episodic or chronic. In episodic, we wanted to know whether it is triggered or spontaneous. Now we are talking about in the spontaneous variety. In the spontaneous variety, extremely short-lasting vertigo in that particular age group. This is this benign paroxysmal vertigo of childhood. There are some differential diagnoses there also. Anything in any extremes of age group, okay, you have to be very careful. Though I have not come across any surprises, but I have been told about surprises even in these things. So it's a good idea to evaluate them. There is nothing wrong in imaging them, nothing wrong, or in fact it is good to do an EEG in them to be sure that there is nothing else going on. It's very important that that evaluation is complete. But the problem is, nowadays, जब हम वर्टिगो का पेशेंट देखते हैं, प्रॉब्लम ये नहीं है कि इसको MRI करवाना ही कि नहीं है. That is not the problem. शायद 10 साल पहले या 15 years बिफोर 15 साल पहले बात ये हमारा कंफ्यूजन ये होता था कि इसको एमआरआई लिखो कि ना लिखो. नाउ वो कंफ्यूजन तो नहीं है. Most of the country we are definitely much better than US and UK in this matter. That nobody already person has come with MRI. अभी आजकल का हमारा दिक्कत ये है कि MRI नॉर्मल निकला, अब क्या करना? This is the problem. So now after the MRI turns out to be normal and all of these things have happened, in this age group, we have a differential diagnosis, that is benign paroxysmal vertigo of childhood for extremely short lasting, less than 1 minute. The typical description is, and children are very smart, they describe very well. They will tell a fan jaisa hota hai. Okay, they will tell earthquake, like whatever, because they have seen videos, they see all these things, so they give a proper description. And as long as it is only, they go and cling on to the mother. If somebody tries to hold, they don't want to. But within 1 minute, everything is gone and they are okay. And it can happen multiple times per day. Okay. If it is happening 10 times per day like that, then your diagnosis leans more in favor of epilepsy. There is an epilepsy form called tornado epilepsy, also vestibular epilepsy. But if it is like once in few days, then it weighs more in favor of benign paroxysmal vertigo of childhood. To make sure that you get the diagnosis more, a family history is very important. So we need to make sure that we get a good family history. In the family history, what are you going to look for? Motion sickness in the sibling. Okay, in this particular age group, motion sickness in the siblings, motion sickness in the parents. Okay, so any of these things have a motion sickness or any obvious migraine history, the diagnosis is made. Okay, so for making BPVC, you need migraine type family history. You need migraine type family history. Okay, anybody, any migraine type family history. At this point of time, it's pertinent to mention in vertigo practice that we should all start writing a tattoo on our hands, foreheads, wherever it is, that one of the reasons why all the time migraine is not considered in our differential diagnosis is because somewhere in the corner of the brain, very strongly it is etched like the 10 commandments. कि migraine is equal to headache. And वो सही नहीं है. Okay, most important thing is it is not migraine. Headache need not be part of the history even when the diagnosis is migraine. There are a lot of migrainous phenomena without headache. That's an important point. So the next thing in this short lasting and split second vertigo differential diagnosis, very very short lasting and split second vertigo differential diagnosis is there are not many actual inner ear causes for the short lasting. Okay, spontaneous vertigo. There are not many actual inner. All the problems start from the nerve onwards. Okay, after the inner ear, there is a connection. This pathophysiological understanding is important for us to catch this patient in the OPD. It starts from the nerve onwards. So when you talk about nerve onwards is the vestibulocochlear nerve. In fact, facial vestibulocochlear nerve bundle. Okay, from there. It is there in the internal auditory canal and it is there in the cisternal segment. This nerve bundle. Previously unrecognized, but now we are very commonly seeing this kind of patients. At least in a month we get 2 or 3 patients like this. There is a true neurovascular conflict in these patients. There's a true neurovascular conflict. Neurovascular conflict used to be a very very controversial diagnosis for a long time, but now we have enough patients responding to carbamazepine, these kind of drugs, lacosamide, these kind of things, that one, now we have to take that seriously and as a real entity. So, neurovascular cross compression there is another cause of short lasting spontaneous vertigo. The only point, what are the points that you should think in terms of this particular person is having? Now, first differential diagnosis हमने जो देखा था वो क्या है? BPVC, benign paroxysmal vertigo of childhood. There the context is, it's a child, short lasting, spontaneous, enough. These many things, nothing else takes. That is it, you got a diagnosis. When do you consider neurovascular cross compression? The diagnosis name for neurovascular cross compression is, the pathology is cross compression, the diagnosis is vestibular paroxysmia. This thing is vestibular paroxysmia. When do you suspect vestibular paroxysmia? Vestibular paroxysmia can happen from the growth spurt year onwards. Okay, somewhere around 9 to 10 years of age onwards. From there, some people, nowadays we are seeing early growth spurts. Previously, in our age, we used to have a growth spurt somewhere around 12, 13 years of age, and suddenly we used to grow. Now we are seeing kids starting to have that spurt at 8, 9, 10 years only. Suddenly they start. During the sudden change in the height of the patient also, these kind of things become very common. In them, when you do a scan, what you will see is the blood vessel which is crossing the vestibulocochlear nerve bundle is in the cisternal segment, not in the internal auditory canal. Lot of the time, all radiologists nowadays are tuned to writing Chowda 1, Chowda 2, Chowda 3 loops in the internal auditory canal. They are less significant for us. What is there in the cisternal segment is more significant for us. That is where the symptoms come more. So that is. Now one is it can happen from the growth spurt days onwards, but then it can happen in any age group. Okay, for this matter. Okay, any age group it can happen. Okay. Other extreme where it can happen when there is a vertebrobasilar dolichoectasia in the elderly people. Okay, so there also you can see this kind of pattern. Now what is the clue in us, in the history, what is the clue that you are actually looking at a vestibular paroxysmia? Any unilateral auditory symptom. Any unilateral auditory symptom is a clue. That can be tinnitus, that can be hearing loss, that can be earfulness, whatever. The moment you get an auditory symptom in a person with vertigo, one beautiful thing about auditory symptoms in a person with vertigo is the localization is only up to, most cases, the localization is only up to the root entry zone, that's all. And beyond. कान में हो सकता है, नर्व में हो सकता है, उसके बाद नहीं हो सकता. Okay, that is the thing. And it has to be this thing. So, people who have gone into vertigo in little deep, their biggest confusion in a person who has gone into vertigo little deep is nystagmus जो दिख रहा है वो right beating है. By classic physiology teaching, the problem has to be left weakness. Okay, that is what is. But we will see multiple times this rule is not followed in clinical practice. So we can, with emphasis, come to a conclusion, nystagmus is not side localizing. Here is where history comes. Nystagmus is not side localizing. Okay, it is not side localizing. Direction of nystagmus is not side localizing all the time. Okay. Auditory symptoms, especially when they are unilateral, help in side and sight localization. Side and sight localization. One is when you get an auditory symptom in a person with vertigo complaints, you know that the problem has to be from the ear to the root entry zone. Ear, nerve, that's it. Nothing beyond, not in the brainstem. Not in the brainstem. So this is very, very important. Auditory symptoms are, and that auditory symptoms can be anything from simple vague discomfort, vague block sensation to tinnitus to actual sensory neural hearing loss, whether it is low frequency, mid frequency, high frequency, wherever some auditory symptoms are there. So beautiful now. Sometimes even middle ear also. I didn't tell about the middle ear. Even middle ear also. Okay. Otosclerosis causes vertigo. Okay. So this much. So one is auditory symptoms. Presence of auditory symptoms tells that this person has. Second thing is vestibular paroxysmia patients show one more behavior. That one is, though lot of the attacks are spontaneous, some are positionally triggered also. Some of the attacks are positionally triggered also. If you see a combination of spontaneous and a combination of positionally triggered short-lasting vertigo, your diagnosis should lean in favor of vestibular paroxysmia. Add to that unilateral auditory symptoms, done. You have the diagnosis. So this can be like a pattern recognition. You see the pattern and you get the diagnosis. So the first pattern you saw was what? A child 4 to 6 years old, repeated, recurrent vertigo, short lasting, less than a minute, and after that everything is fine. There only you write diagnosis B, P, E, C. But take an opinion. Okay. Involve the neurologist, because always it is not. There are sometimes surprises come, so good evaluation is also needed. Once everything is done, you know how everything is done, everything is clear. To the mother, father, you can tell in the beginning only, this looks like a condition called BPVC, which is part of migraine. Don't worry, but we have to be sure. So we need to do an evaluation, finish the evaluation, everything is over. then do this. Okay. Especially in the hyperacute stage, in the if the history is very short, less than a month short or whatever, the history is too long, then nothing much. So this one is extremely short lasting, vertigo, vestibular paroxysm. There are some people, in the history wise, somebody would have made a diagnosis, like sometime some visual symptoms, history would have happened, all of those things. This is vestibular. There is another condition called paroxysmal brainstem attacks. Paroxysmal brainstem attacks. Paroxysmal brainstem attacks is again a cause of short-lasting vertigo, but here you will not see any auditory symptom. Okay, here you will not see any auditory symptom. The reason is, okay, epileptic transmission in a previous multiple sclerosis stroke. There the history would suggest, okay, this patient previously used to have some visual symptoms, some unrelated sensory symptoms in different parts of the area, all of these things, and then you get a diagnosis. It's not very common. Okay, vestibular paroxysmal brainstem attacks, at least in the Indian population, we don't come across that usually. Okay, so that is one. The other thing that suggests the problem is actually in the brainstem is rather than spinning vertigo, when you should actually, based on the history and the complaint, you should start suspecting this one is, their complaint is tilt illusions. Tilt illusions. Short lasting, sir, aisa full room, aisa ghum jata hai, and then it comes back. Okay, it just turns, the entire room goes like this and it comes back. If they are telling something like that kind of a story, then you start suspecting possibly it is because of a paroxysmal brainstem attack.
Sir, in BPVC also patient complaints of this kind of thing sometimes.
BPVC, they will tell about fan spinning, all of these things. They tell everything. In BPVC, usually it lasts somewhere around 1 minute and it is continuous sensation. And it's a continuous sensation. That if they tell this, it keeps rolling. In paroxysmal brainstem attacks, it goes within a second, it comes back.
Oscillated.
It just goes. If you are seeing the room, since suddenly this room is placed upside down, and then again it is set right.
So one more thing. The auditory symptoms, they are temporary in this vestibular paroxysm?
No, sir. They can be permanent.
But suppose the patient is already having tinnitus and all.
Yes.
And
then on top of it, they are getting short.
2 years he develops vertigo.
Doesn't matter. You have to, if the vertigo is short lasting, then always have a high suspicion of neurovascular cross-condition. Okay. The auditory symptoms can be long. Yes, sir.
In vestibular parallelism,
Yes.
so why not the auditory symptoms parallel the frequency of vestibular?
It can happen. It can happen. That also is there.
Not routine. Why it doesn't parallel the frequency of
Probably the auditory nerve is little more prone to damage. Possibly compressive damage, auditory nerve is more prone, or auditory nerve, once it is there is a beautiful thing about vestibular system, its ability to keep retuning itself.
Or there is some kind of somatotropic organization inside the vestibular nerve or auditory nerve.
You talk about this thing. So when you look at the organization, there is a vestibular, superior vestibular nerve, inferior vestibular nerve, there is the facial nerve and the cochlear nerve. And then this is the anatomy, but then the anatomy gets twisted as it enters though. But that anatomy is there. So vestibular nerve definitely is actually more exposed than the cochlear nerve. Actually, if you go by that, then it is more exposed. Possibly the cochlear nerve's ability to retune itself is not. Vestibular nerve is known for retuning. Little damage happens, it just readjusts because the other opposite side. When it comes to auditory, 1 year, this year, is separate entity, that year is separate entity. The full organization happens at the cortical level. Whereas when it comes to the vestibular nerve, this side and that side work as a unit. Okay, I'll come to that again. Okay, they work as a unit. So that is. So this is
Sometimes a
about.
patient complains of this thing, history looks like a paroxysmia only. But when you get an imaging done, they says
Need not
type
be.
1 and that
Need not
then we
be.
have to treat as a paroxysmia only or
No, with
something
the,
else.
I go by the history. I go by the history. In fact, Barney Society has not placed imaging finding in the diagnostic criteria till now also. There's a huge amount of debate even within Barney Society to update the diagnostic criteria. People have not accepted, the people who are the decision makers have not accepted in adding the MRI. Okay, they are not adding the MRI. Maybe there are multiple reasons. The reasons is MRI is done in a different posture, in the supine posture, whereas most of the symptoms are happening in the upright posture. What small changes happen in the relative anatomy in upright posture versus that, we don't know. So those things are there. So, but it is not a must. If the history suggests, even in presence of an absent MRI, I will still give a therapeutic trial. I have done this. I have done this with success. Okay. So this is the. And the other side also is important, where there are a lot of patients who come, history is absolutely not suggesting with a loop report. That also I am not going to give. These 2 points are very important. Okay. So don't give so much emphasis to radiological report. Okay.
Treat the patient, not the image.
Huh?
Treat the patient, not the image.
That is the rule from second MBBS onwards. We have been treat the patient, not the X-ray. We started off from there. Now from X-ray, we have, only thing is X-ray has been changed to MRI, but ultimately it is the same. Okay. You can treat the patient, not the VNG, especially if the VNG has been reported by somebody else. Okay, that is also very important. Very important, because we see that kind of lot of confusion keeps happening. Okay, I have seen so many patients. Clear-cut nodulous problem reported as labyrinthitis. Okay, so like this we have seen these kind of problems. So this is true for all investigations for that matter. So now let us proceed to the next level. Now what happens? There is one more reason why you get a very, very short lasting push sensation, pull sensation, something like as a chakkar, it comes and it goes. And this is the commonest in practice. Patient tells, they will come and tell, sir, suddenly I'm doing at my desk, I'm doing the work, and suddenly I get this. I feel like I'm going to fall. What is this? Now, if you have been sleep deprived and if you have been driving, who has not experienced that? One pull of sleep. Correct, one pull. My God, bunch gear. Like that, you know. There was one particular time, maybe you can ask people like, how long can somebody go without sleep? Somebody says 24 hours, somebody says, what is the longest anybody has done without sleep?
I've done 72 hours. I have done 72.
I have done 72 hours. I have done 72 hours, not because I wanted to do, because there was one day, another day. One day I was organizing, we had in MS Ramaya, there was this advanced learning center. It was a passionate project. If you see that one of the best cadaver-based training labs is there in MS Ramaya. I was in part of the setting up of that cadaver-based thing. So the last day, inauguration is next day, the last day I have to do. So I worked full night to set things up. Then my sister-in-law had a miscarriage. She was there in her native place. After this full night, next day, I drove my car, took her in my car and came back. And the next night was this thing, inauguration previous day, some more work was there. 3 nights. But in that, I noticed, which I never told any family member, is that at one point of time I felt this. And I didn't know. After waking up, my car was still steady. Otherwise, okay, I don't know. What happens in road traffic accident is this, like one moment is that we should never do that. Okay, but I ended up doing it at that time, but we should never do that. So this is the, but why I'm telling this with all this story, everything is, one of the commonest reasons for this is sleep deprivation or disturbed sleep. There are some people who have long-term sleep deprivation. Any person with short-lasting vertigo, an adult, your first question should be, what is your sleep quality? Okay. Short-lasting vertigo, sleep quality. What is your sleep quality? Because if you are not sleeping well, then if you ask, what is the relation to sleep? Do these attacks become more when you have been sleep deprived for whatever reason? They will tell, yes, when I have been sleep deprived, it becomes yes. That is true. Here, it is important to mention a phenomenon called brain zaps that is known in colloquial language. Brain zaps is where suddenly they feel electric shock-like sensation, sudden vibration-like sensation, sudden this thing, and they are okay. This is very common in people who have been on antidepressant and they're coming out of antidepressant, especially selective serotonin reuptake inhibitors. This is called antidepressant discontinuation syndrome. ADS, antidepressant discontinuation syndrome. In antidepressant discontinuation syndrome, the exact kind of brain zaps that they report, the symptoms that they report, sudden electrical sensation, sudden movement of the head, sudden jerk, sudden whoosh sound and then stops, everything. Everything sudden and then immediately it goes. And then they are good. After some time they get set right, or you just need to reintroduce the antidepressant, that is the serotonin, and then slowly again re-taper it, but more slowly, and then the person becomes okay. This is called antidepressant discontinuation. For some reason, the exact kind of symptoms that we see in antidepressant discontinuation syndrome, we also see in patients who are having sleep deprivation because of obstructive sleep apnea, because of these things. So, description. So, if the antidepressant discontinuation syndrome is because of momentary deprivation of the synapse of momentary, very short lasting synaptic serotonin deficiency, momentary. Possibly even here it is something like that. Some of these neuro, it may not be only serotonin, it may be norepinephrine, it may be so many things, but it is, if it is happening in one context, possibly it is also happening in another context. This will be hypothetical, this will be this thing. But then once we start collecting all these things, maybe one day we will come up with a new diagnosis, a name that was first mentioned in ChakkarCon. Okay, momentary synaptic serotonin depreciation. Okay, I don't know. Okay, now it will become another MSSD. I don't know. Okay, it is not written anywhere. Okay, but if the brain zaps, because this is very common. Again, here the treatment lies in treating, making the person sleep well, but adding magnesium, magical in this group of patients. Magnesium has been magical in this group of patients. First is it makes them sleep well. It makes them sleep well. Especially at night, it makes them sleep well, magnesium. I am not maintaining the purity of the topic that it is only history. Okay. So, it may not, but clinically it is relevant that we just do this as we are doing it. Okay. And then taking care of their sleep. This is one. Then the last one at the top is again epilepsy. Epilepsy can cause very short lasting recurrent vertigo. Here, history of presence of deja vu, jamai vu, these kind of stories is again very important in these kind of patients to find out whether it is possible that family history of epilepsy, and if not anything, just do an EEG. There was one particular patient which always I like to mention about this particular patient. The patient is somewhere around 32-year-old in down south. Usually in those traditional families, by 21 years only, 22, that's the case here also, not also, I know, 21, 22, 23, lot of these traditional families in the villages and all those things. By 24, if you are not married, means why are you not getting married like that? So, 32-year-old lady in that background where she was coming from Pagalkot or something, is like too much of pressure on all of this. She used to get this recurrent short-lasting vertigo attacks, like few seconds, multiple times per day. I first thought there was no auditory symptom, there was nothing, there was no positional, nothing. But then those days, the only other differential diagnosis I knew was paroxysmia. I tried to treat, it was not coming down. Though it was, paroxysmia also was anti-epileptic use, she was not. Then I discontinued that, tried lot of medicine, but she was not. The other thing at that time is, okay, 32, lot of pressure, she tells, ask about pressure, tension. She tells, yes, there is a lot of tension. She works in a bank, there is a lot of pressure, family pressure is there, lot of things is there, personally she is going through a lot of stress. Then you think that this is all because of that. And finally, when the final diagnosis we made based on EEG, it was epilepsy. And then she did respond to one of the other anti-epileptic agents. I really don't remember what the neurologist gave her, but then she started responding. Okay, so like that. Now what happens is, these are all red herrings. Okay, like there are other things which tell, okay, there is stress, hey, all these things are there. Therefore, you think because the stress factor is 100%, 200%, you want to attribute the physical problem to stress. The person may have a lot of stress, but if he has appendicitis, it is appendicitis. You will not treat the stress. You will not attribute appendicitis to the stress. You will go and treat them. So this is very important even in vertigo practice. Lot of time we make this mistake that the moment you see every demographic pattern, every other pattern of the story tells that it is stress, so we should not attribute automatically the complaints to stress. So this is one very important point. So from one side, we saw for the momentary disability, all these things. In the elderly age group, here is one place where again, for short-lasting vertigo attacks, you will get an explanation in the elderly age group. And that one will be a dolichoectatic blood vessel pressing on the medulla, okay? It's a huge dolichoectatic blood vessel. I mean, when you see the vertebral arteries and the basilar artery in an MRI, vertebral comes nicely from one side, both sides, they touch, and there is a basilar artery, it goes straight up, and then all the divisions are happening. Whereas in this person, the vertebral artery does not come like this. It goes like this and it comes like a snake. Then the basilar artery goes like this, it goes up like this. So this is called dolichoectasia of the vertebrobasilar blood vessels. If you see that, then again one part of the vertebral artery will actually be pressing on the medulla. It is being described as a vertebral artery compression syndrome. There are published papers on this, vertebral artery compression syndrome. They are also called as medullary compression syndrome. These are published papers. And the mechanism that they tell is not exactly the compression, but a short-lasting hemodynamic change in the blood vessels that are emerging 90 degrees to them. Okay, so there are blood vessels which emerge 90 degrees to them, which go into the brainstem. So there is a short-lasting thing, and they again for some reason respond to ecosprin. For aspirin they respond. So these are the differential diagnosis of short-lasting. Now after having done the very, very short-lasting, starting from the very young to the very old, we have covered everything, all the age groups. Huh? All the short-lasting vertigo, they deserve a use. Okay, all the short-lasting vertigo. Nowadays, they deserve a complete evaluation. Okay, I am not a chauvinistic person like my old days when I was in Bangalore Medical College MBBS days. We used to have professors who would scold us for ordering CBC instead of asking for only PCV. Okay, those days. We also belongs to a day when our thyroid diagnosis used to be based on, hyperthyroidism used to be based on sleeping pulse rate. Okay, but those days are not there, and it is good that they are not there. Okay, it is good that they are not there because so many diagnoses we can make based on an investigation. Okay, so whatever. Just see what one COVID did and one this thing did. Labs became so beautiful. Previously PCR was a big technology. Now PCR is there everywhere. So like that, things are changing. Yes.
So, that daclotasia of basilar artery or vertebral artery, I've seen one patient in which patient didn't have these small episodes, but had a classical positional vertigo when
possible
lying down downbeat in nystagmus and
absolutely. So that is one more
got an MRI and had a huge
I wanted to come to that later, but I'm mentioning right now only. So that one is disabling positional vertigo. Okay, disabling positional vertebrobasilar dolichoectasia. Again, you can see them. Okay, disabling positional vertigo. So that also is possible. That was described both in paroxysmia, the classic only loop also, but it is more common in the. If you do a hyperventilation test in that person, you will even be able to elicit either vertigo or facial spasm in some of these patients. Okay. So it is possible. Yes, sir.
So like you told about the brain GD.
Yes, sir.
What is the word like? Can we call it a transient alteration of alertness?
Absolutely. Absolutely. You can call it. We need not. What I am trying to do here is previously what used to happen in the approach. What has changed now in our approach is previously what used to happen. A vertigo hai, nahi hai, a mera case hai, nahi hai. That is how it used to happen. The problem is patient was not being there. Now patient mere paas aaya hai, wo mera. That is it. Because of that, whether it is a vertigo symptom or not, that is why I never get the history. Everybody starts the history how the vertigo classes used to be taken in the beginning days was based on one particular paper which has been discredited now, and that one is it true vertigo? Is it dizziness? Like this. There is a paper from which this came. 4 types of vertigo. This is a discredited paper. Unfortunately, whenever I go and sit in any class, any vertigo session, the history starts with that. Okay, type 1, type 2, type 3, type 4. Okay, true vertigo, dizziness. The entire paper has been discredited. In fact, that paper should be withdrawn. Okay, like that, because it made a lot of wrong assumptions. So that one. Now what we are doing is, whatever it is, patient. And then there is a very nice new type of thinking, and there is a paper on top of that. Is exact description of the symptoms are not important. Times and triggers are more important. So that is why the concept came, timing and the triggers, rather than description of the symptom. To emphasize this point, people who are doing regular vertigo work every day, they will vouch for the fact that number of patients of 100% proven treated BPPV in whom they don't mention rotatory vertigo. I have patients who come and tell, okay.
Sir, online में थोड़ा problem है that's all.
ठीक है. So what is happening here is, so it's I was talking about BPPV non-rotatory. I have a patient in whom he only tells, sir मेरे को घबराहट होता है, I am anxious. कब होता है? Sir, लेटने से. I am anxious of lying down. I am anxious of turning. That's all. He never complained. He never complained. So this is the thing. So now how do you say what is what? Best is we have the tool, just do the test. If you get it, because BPPV, treat it, his anxiety is taken care. There is a particular patient, there is Dr. Pradeep, who works in NIMHANS. There was a child who was being treated for bipolar disorder. She started getting these attacks. Okay, achanak se, suddenly some dizziness. Everybody thought it is like there is a dose readjustment, that, this, and all these things. They tried everything, nothing was working. Finally, they sent to the audiology department. Kuch karke dekha. BPPV. BPPV. So like that, so that is why this thing. So let us go by any momentary phenomenon. And then what all we know so far to try to find an explanation for those momentary phenomena of space-related disturbances.
So in these patients, will we get the diagnosis or not?
Which one, sir?
In these diagnoses.
In BPP you are talking about, nystagmus आता है. इसीलिए we know that it is diagnosis. So we do get the BPP. Okay, we do get the nystagmus. On the positional testing, we do get the nystagmus. BPP itself and the nuances we can do one day workshop. That's a different issue. Where there are other possibilities where clear BPPV in whom symptoms are not coming, clear BPPV in whom the nystagmus is not coming. Like that it is there. But then in these kind of patients you will get. So now we are done with the short-lasting vertigo. I mean short-lasting dizziness, vertigo, brain zap, whatever you want to call it, short-lasting attacks. Now we go to a group of conditions where the spontaneous attacks, the spontaneous attack lasts for a few minutes to hours, sometimes even days. Here, there are not many differential diagnoses for practical purposes. You are working in an institution, you want to make a huge number of diagnoses, okay, like a quaternary care institution where you have a lot of genetic testing, all of those things available. You can do much more. But in day-to-day clinical practice, there are not many differential diagnoses here. The main differential diagnosis in the short-lasting vertigo attacks are Meniere's disease, vestibular migraine, transient ischemic attack. Meniere's disease, vestibular migraine, and transient ischemic attack. Where the episode lasts minutes to hours. Now, when do you make a diagnosis of Meniere's disease? You make a diagnosis of Meniere's disease, especially when there are clear unilateral auditory symptoms. And those auditory symptoms are time locked to the vestibular symptoms. What is this time locking? Time locking need not be exactly together. It can be just before, it can be just after, or going along with the vertigo attack. Patient tells, sir, my ear starts getting blocked 2 days before. Some people tells only half an hour before. Then after that they start getting the vertigo attack. It can start 2 days before also. Okay, 2 दिन से मेरे को, they tell 2 दिन से मेरे को ऐसा लग रहा था कि दूर की आवाज बहुत जोर से सुनाई दे रहा था, ये something that was very far away. It is telling that cochlear dysfunction has set in at this particular point of time. Cochlear does two things. It enhances low sound. It suppresses high sounds. Okay, it's the dynamic. It's a beautiful sound modulator, whatever you want to call it. Okay. What do you call the what the DJ does? Increasing, decreasing, whatever. Okay. So
Tempo.
what's that?
Tempo.
It increases decay. So cochlear can increase the low volume sounds and reduce the high volume sounds, the perception. Okay. So this is called dynamic range. Okay, the dynamic range. The first dysfunction, cochlear dysfunction is actually the alteration in the dynamic range. Okay, the alteration in the dynamic range that will happen. So they will have some complaints like that. Then they will tell fullness, all of these things. Tinnitus will be there. Okay, roaring sound that they will start hearing, or whoosh sound, whatever. Some people tell that also. Every kind of sound we are told in the history. Then after that or during that, they will get a vertigo attack. Sometimes they will tell ear suddenly khul gaya. Suddenly it was blocked for 2 days. The ear suddenly opened up, and then I started having the vertigo. So all the different complaints that they will tell, and then followed it. So you have this thing. Just because somebody tells tinnitus, hearing loss, and vertigo, three things together, simply don't jump to a conclusion of menieresis. Don't jump to a conclusion of menieresis. Very important this point. Because it can be vestibular paroxysm, which are all these three things, but in a temporal sequence is totally different. Okay? There is a background tinnitus. Okay? There are a lot of people with migraine with a lot of background tinnitus. Okay, so like this, just because the temporal association is important to make this diagnosis. Of course, when you do the investigation here, you will see a typical pattern. They would already gone to 2-3 doctors, 2-3 places they would have done an audiometry. If there is no correlation between one audiometry to other audiometry, it means not the audiologist was wrong, it means if the person had a fluctuate hearing. Okay, it means the person had a fluctuate hearing loss. Okay. See, if somebody sees a heart on the other side in an X-ray, first thing we do is we blame the technician. But if the technician was right, it is situs invertens. Correct? No. Like that, if the audiometry, 3 audiometries are looking like 1% did not do well or 2% did not do well or all the 3%, rather if everybody was right and still the audiometries was bad or different, then we are dealing with a person with fluctuant hearing loss. So this is how we place that particular story and take a diagnosis. In Meniere's disease, very commonly you also see isolated cochlear involvement or isolated vestibular involvement in the beginning of the course. Okay. There it will be called either cochlear Meniere's or previously so-called atypical Meniere's disease. I don't like the word atypical Meniere's disease. The reason I don't like is atypical can be any atypical. Somebody first mentioned it for cochlear Meniere's disease, wrote it in Scott Brown, does not put it in bold. If Scott Brown is wrong, it has to be changed. Okay, that is not a correct word to apply because it can mean anything else, any non-typical presentation. So we should stick to cochlear Meniere's disease as a separate conclusion. Eventually, history will take it to the proper Meniere's and your diagnosis will be easier. But what we should know here is fluctuant hearing loss can be one of the presentation of Meniere's disease in the early. There are some other people in whom you will see fluctuant, you will see only vertigo symptoms, but during the attack, you ask nowadays everybody has good quality mobile phones, ask them to start recording with their mobile phones. When they record with the mobile phones, and you can actually see a nystagmus during that episode, and the episode has lasted long enough, no cochlear symptoms, we should keep our mind open that this could be isolated vestibular Meniere's disease, eventually will progress to full Meniere's disease. So both are possible, keep that in mind. And we should start using mobile phone like anything nowadays. Okay? There is nothing better than present day stethoscope is mobile phone. Okay. I will show you so many more things that you can do with the mobile phone eventually. Okay. The next thing here in this particular group of differential diagnosis is vestibular migraine. Vestibular migraine. I will tell you in so-called Meniere's disease when you start suspecting that it is actually a migrainous phenomenon. The sun does not both rise and set on an episode of Meniere's disease. एक्सप्लेनेशन. सुबह 4 बजे को उठा सर, तब से स्टार्ट हुआ है. शाम 6 बजे तक it would have gone. By the time sunset, because एक sunrise तो देखा है, the episode. That episode will not see a sunset in venereal disease. Okay? Somebody at 4 o'clock, it starts in the evening. He is there 10 o'clock, 11 o'clock, 12 o'clock. Next day morning 6 o'clock, okay. It will either see a sunrise or it will either see a sunset. It will not see both a sunrise and a sunset. This is the beauty. That is also the reason why I tell a lot of people who are suffering with Meniere's disease, sir, kya karna hai? They get so much, they are doing all of this nonsense. They go get admitted, do all of that. I tell them just take a tablet, sleep in one day, room, and finish it off. That day you apply leave, whatever you want to do, sleep off. That episode will go off. Now if you go here, there, going to the emergency, then from there going here, by then you will be tired, physically drained out, pocket-wise drained out. Okay, everything drained out. So don't do this. We tell them please just sleep off in one particular place. I have taken care of patients. This one information, I've taken care of patients. They tell, sir, I want to go traveling in US. So some of them travel. Then one day one gentleman asked, sir, I am getting an attack now. What am I supposed to do? Can you afford to cancel 2 days? So, yes, sir, I can cancel. Just sleep off. Don't go to any hospital. It will not be there till sunset. Because we know the condition, so we can guide the patient correctly. He slept off, he's fine. Then he came back and said, thank you. That one word on the phone call, on WhatsApp call, that you told, sir, nothing will happen, was enough for him. Otherwise, it's very scary at that particular time. Sir, going round and round, something else will happen and all of this. So, this is about Meniere's. So, if it is lasting both sunrise, sunset and everything, the other differential diagnosis, of course, longer duration and very short duration. Different kinds of duration is there in this same thing, vestibular migraine. And in today's vestigo practice, the commonest diagnosis that we are turning out to be seeing is migraine. The day you recognize migraine, the day you can treat BPPV well, that day you can put a big seal on your certificate, vertigo specialist. That's all. Previously, it used to be in the beginning days, even when I was not born, those days, my professors used to tell me that what their professors used to tell. If you know syphilis, you know medicine. You know politics also. You know Lord Mountbatten also. You know Nehru also. So many things you know. But later on it became, if you know tuberculosis, you know medicine. Similarly, if you know migraine, you know vertigo. That is the ways in which a migraine can present to us. What are the ways in which a migraine can present to us? Extremely short-lasting. Extremely short-lasting vertigo. 2, vertigo lasting even up to a week. It can happen in migraines. And if in a single patient you see all temporal patterns, sir, एक बार 5 मिनट में जाता है, एक बार 20-10 मिनट रहता है, एक बार 2-3 घंटा रहता है, एक बार तो 1 हफ्ता था. You are talking about a migraine, vestibular migraine. Again here, repeating to rewrite our tattoo, don't equate migraine with headache. Here, counseling the patient is also important. आपने तो diagnosis कर दिया ये migraine का है, but patient को समझाना बहुत मुश्किल है. Because these cognitive biases are there in us. This is there in humanity. It is meant to help us to optimize on thinking and all of those things. Okay? The cognitive biases, to fight cognitive bias is very, very difficult. Somebody, some person, this thing, you always tell that this is the behavior. A tiger cannot be herbivorous. It is fixed. Even if you prove that it is eating grass, then also people will not believe that it is. Okay, that is the thing. Because these are cognitive biases, okay, that all of us have. And that is there for a reason, to protect us. Because we have been made for survival. It is good. But the problem here is some of these cognitive biases can mislead us. One of the cognitive bias is always thinking migraine is equal to headache. Now the patient also has this. You tell migraine, patient tells sir. Sir, okay. So you have to use a different word to tell the patient the diagnosis. Kya hai? So what is the diagnosis? Non-headache migraine. The moment you use the word non-headache migraine, suddenly the cognitive bias is broken. It is suddenly broken. Sir, ऐसा भी होता है क्या? And then you tell yes, ऐसा होता है. Describe it. Okay, all of those things. Okay. Then you can do all of these things and then explain. This is very important because convincing. Otherwise, they will not take the drugs. Then 3 months later, sir, आपको मैं दिखाया था 3 महीने पहले, अभी तक सही नहीं हुआ. ठीक है. You also have a cognitive bias. You assume that आप जो दवा दिए थे, वो खाया और सही नहीं हुआ. Later on, you ask the next question, sir नहीं लिया. तो कैसे सही? We have seen this. I didn't take the tablet. Why? Sir, you are telling migraine. But like that they will think like this. So this is very important to use the word non-headache migraine. Okay. So this is important to tell the patient and then make a diagnosis. Is that okay? So this is about the migraine. So what are the things that will actually tell you that this person actually has a migraine? Start from, this is the one where you have to start the story from the story of the Khandan, not just from the childhood, not just this thing. Mother, father, siblings, everybody. Okay, so I will tell you, motion sickness history is very important in any first degree relative. It could be anybody, it could be a sibling, it could be mother, father, anybody, any history of motion sickness is very important. Now the history of motion sickness is in a personal history. I will tell you, just 2 weeks ago I had a child, 14 years old. Any motion sickness, any problem in the buses? No sir, I don't have any problem. Then the mother immediately points out, but if you eat, it will be a problem. I stopped eating before going in bus. Then what? He had stopped eating when he is going in the bus because he is having motion sickness. Because he is having motion sickness, he stopped eating. This kind of stories are very important. That is why ये chat GPT, ये artificial intelligence कभी भी diagnosis सही नहीं दे सकता है. Because patient will think they will write what they have. I had a patient in the flight. He had a syncopal attack. Suddenly he stood up. He had a syncopal attack. He fell down. After standing up and after walking. Why did he stand up? He felt nauseous. Therefore he stood up. Then he had fallen. For me, this guy upright, this sudden upright posture after this happened. This was a cardiac syncope. For me, it was cardiac syncope by whatever context, whatever. I put him down. I checked his blood pressure, everything. It was a little low. Okay. Then I was monitoring. I didn't make him. I made sure that fellow does not rise. It's there. Again and again, heart का कुछ problem नहीं sir, कुछ नहीं. Heart का कुछ problem नहीं sir. I must have asked some 30 times heart का कुछ problem है. Patient told no. Patient related, everybody no. How many times they said no, I don't know. Then finally, for some reason, आप बेंगलोर क्यों जा रहे हो? वहाँ कोई है क्या? नहीं sir. नारायण हृदयालय एंजियोप्लास्टी के लिए. Then I wanted to know the reason why heart का कुछ problem है तो why were you telling no? डॉक्टर ने बताया कुछ problem नहीं है, अब जाके ऑपरेशन करो. Now tell me, these are real life scenarios. This child is asking, I am asking, do you have a motion sickness? He is telling, I don't have a motion sickness. Then mother tells that if he eats, then whenever he eats, he has vomited. So he has adapted himself. Now he doesn't have because he has adapted himself. This is why the story is very important and the art is as important as the science of this. Motion sickness history is very important for the diagnosis of migraine in the family or in the business. There are a lot of ways in which they tell. The way they do picnic. What precautions do you take when you are taking picnic? Maybe we should start asking more specific questions. So you eat and go, no problem. Next thing is, did they like swings?
Do they like swings? This is a very important point. People don't like swings. Migraine people don't like swings. Lot of people. Okay. If the person did not like swing, everybody liked the swing. The migraine person tells, sir, I used to do also, but afterwards it used to be so bad. It is like, next day is going to be hangover. फिर भी लेते हैं ना. So I saw swings, so they like it. Okay, so all these things are there. So only till Prateek connected for only one point that I told, the hangover. Right. So this, yes sir.
So in one of the papers, it has been said that if you cannot read comfortably, while
Absolutely, that was the next
in
point.
a
You're reading my
car-
mind. You're reading my mind.
in a car, it should be taken as a motion.
आपका क्लिनिक के बाहर बोर्ड में अभी सिकदर बाबा जी बोलते okay. Because you are reading the next point. Okay. The next thing is these people cannot read while they are in the car, while they are in the bus. Even if they read, after reading and suddenly they lift up, or suddenly they come up, it's very bad. Okay, they get a headache, they get very bad sickness. Okay, they feel a very huge amount of sickness that these people get. Okay, these are so intolerance in. Some people have very high sensitivity to any kind of stimulation. Very high sensitivity to any kind of stimulation. For them, a fan, if you tell, you will have somebody in the house, if you put the fan at 3, बहुत तेज है, 2 बहुत कम, वॉल्यूम 11 ज़्यादा है, 10 बहुत कम है. In the TV, 10.5 चाहिए लेकिन वो नहीं है. 2 और 3 के बीच में फैन चाहिए, वो नहीं है. I know some people here may have I know all the self-realization. I'm seeing. Okay, this is what is happening. This is a market. Angry when hungry. Angry when hungry is a migraine phenomenon. It makes people very, very irrational. Episodic irrational behavior, which some of the decisions they take in that irrational state, they regret it for their entire life. That kind of decision some people take. Migraines. And then in ladies, there is no, we should discard the term premenstrual tension. It is migraine. It is harmonic exacerbation of migraine. The other less recognized in the just before the onset of menstruation, whatever happens, everybody relates very well as a hormonal alteration. But we should also see in a lady, if it is related, if it is periodic, exactly monthly, though it is not related to the exact date of menstruation, it can also be hormonal related, because throughout the month hormonal, during ovulation time there is hormone. Okay. So those things are happening, so that also we should, again, migraine. Okay. So if there is a monthly periodicity to the symptoms, then we should again think in terms of, there is one beautiful patient's description of a monthly fall. Every month fall, one fall, turned out to be responsive to treatment given as migraine. Okay, so like this. So these are the things that are there which tells that this particular person. Most important thing is motion sickness. Of course, phonophobia and photophobia. Now, I want to tell some extra tips about what I take history in these people with, you have to tell me about the time. In these people, I want you to tell some extra tips that I take in these people with recurrent vertigo, especially the migraine type recurrent vertigo. So any duration is possible. Second thing is, migraine can be any kind of symptoms. It need not be only spinning vertigo. Migraine patients also complain of head motion dizziness. Whenever they shake the head like this, it is very, very troublesome. But the only thing what it tells it is migraine, it is episodic nature. 2-3 दिन रहता है, बाद में 1 महीना कुछ नहीं. Okay, it is just head motion dizziness. Visual vertigo. What is visual vertigo? Seeing anything fast moving in front of them is very, very troublesome for them. Phonophobia will be there, photophobia will be there. in these people, again episodic. So you ask all these points, they written. Now the extra additional point, which are generally not written in the books, is this about scents, deodorants, room fresheners, all of these things, car fresheners, all of these things are big triggers of migraine as well.
When making food, bagar dena jo.
Absolutely. Agarbatti, camphor. I have a person who is an archaka in this thing. So off late he's developed, he's done it all his life, but off late he has developed again recurrent vertigo attacks, very bad vertigo attacks. And when I ask him, he only tells that whenever he goes, because he's very senior and people consider him very auspicious, they call him for the puja, for doing the homa and all of this. Every day after the homa, he's out. So he is off late not being able to tolerate the fumes and all of those things the homa is able to generate. He was doing it all his life, but now he's not. So for this, Dr. Thomas Matthew from neurology in St. John's, he uses a word called kindling. The kindling is, this has always been troubling him, but the wound for the neurons to get kindled, it took so many years. Okay, and now they are getting the symptoms. Okay, he uses the word kindling for this. In fact, he says that even some of these trigeminal neuralgias are kindling behaviors of these so-called essential oils which are not essential. Okay, lot of things. If you hit in essential oil on Google, you will get so many things. It will cure everything. Essential oils cure every condition, it is written there. But then, if you just hit essential oil on Thomas Matthew, all the bad things will come. Okay, all the Thomas Matthew. Lot of neurological descriptions are there. There are childhood epilepsies because of eucalyptus. So the next thing coming to eucalyptus. Use of eucalyptus at home. Okay. Even the grandmother can be using eucalyptus and the grandchild can be the sufferer. Okay, and they would never know. Carval plus inhalant capsule. We have people actually having seizure attacks after inhalation of Carval plus. Okay. So these kind of things. Okay. Carval plus ka sponsored by me. So these things is the next important thing, because lot of time drugs will not, only drugs are not controlling, but the moment you know what is it is camphor or eucalyptus, you remove camphor, you remove eucalyptus, you remove pudina, menthol. And then in some people methi. Okay, in this thing we do a lot of like seeds in the dosa we put. Okay, remove that. A lot of people, sir, I was thinking my problem is because of Ushna, that thing. I started using the same methi again and again, more water every day morning, and it is becoming more. I stop it, patients all complaints are gone. Okay, like this, including herbal, whatever they are taking. So with the drug history, you should take about all of these. This is an important part. I want to tell one story. There was one guy who, finally we found the solution. My drugs, all drugs are not working for him. He wanted to go to Sabarimala. I told, okay, go to Sabarimala, I give this thing. He liked me because I talked, I listened to him on all of those things. But symptoms are not coming down. Whatever you do, symptoms are not coming. Then finally he told, sir, ये क्या हो सकता है? Again, the start. This story would have been over, but again it can be in anything. It can be from this thing. How I changed all the story also I will tell you. When I just finished MBBS, I mean MS ENT, and I was practicing in MS Ramaya. One lady, one son, both of them came. He had a pharyngitis. I gave antibiotic, proper bacterial pharyngitis is there, pharyngotonsillitis, whatever. And then I told, sir, किस कारण से होगा? I told, अंदर क्या मतलब है, किसी से भी हो सकता है, किसको मानो? दवा लो सही हो जाएगा. I told and I said, corridor, they are talking. कैसे आता है मालूम नहीं इन लोगों को, लेकिन डॉक्टर बनते. From that time, I also improved. Feedback, we have to change, no? Now they said, it can happen because of water, it can happen because of air. कहीं ना कहीं water गलती होगा या sir. Now they are so encouraging. So we have to change. Okay, like that. So we are hyper truthful, who knows, versus now. That's okay. But then this guy I was talking can be from anything. It can be from some smells, it can be some foods. Then he asked me, sir, groundnut से हो सकता है? हाँ, groundnut से तो हो सकता है. Then he immediately tells me, sir, this attack had gone to my native place to my mom makes groundnut chutney, groundnut sweet, groundnut, so many varieties in groundnut you can prepare. If a mother loves, the mothers love everything, because I love groundnut. And I had binged on groundnuts in the last 1 week, and then I came back. And now he stopped groundnuts, his problem solved. There is one more story I want to tell like this, because this migraine, this is very important to identify the exact trigger so that we can do. There is a KS officer, okay, who I used to treat for BPPV for a long time. Now she used to get again and again very bad vertigo attacks, like vestibular migraine attacks, new ones. What is happening in her life? And I asked just like that history, story, all this. Finally, came to know that she has suddenly changed her one department to another department. She has changed to another department. And this particular, then what department? Which department? So and so. Oh, I know that IAS officer. I told the name of that particular officer. Seems to be a good guy, but he's a little crazy guy. Ah, sir, he's crazy, sir, but he's good, sir. Then in this conversation, it came to know that, and then, sir, always he wants some nuts, almonds, that this for his table. Whenever I go, he offers me, and I think, so nice person. She was telling about a nice person, I got the actual culprit. The change that has happened is she is taking these nuts, almonds, what that her boss is taking, the same thing when she goes to the chamber, whatever, she also takes 1 or 2 almonds, and that is enough. Stop that, her attacks gone. How to identify? This is where. So I tell, a good physician is a good human being, great observer of society. We need to be observers, very good observers of society. What is happening in the family? What is happening there? What is happening there? All of those things. To the extreme extent that in my neighborhood there used to be a person who once in 6 months, I grew up in a neighborhood which was coming up in Bangalore. It was all fields. My house was one of the second houses, then third house came, fourth house came, fifth house came, over 10, 20 years, houses came. This lady every time, once in 2 months, once in 3 months, she would go get admitted with severe gastritis. And then full, those days Rantac drip they used to give, 2 to 3 days Rantac drip, and then she used to give. Then finally, the pattern was picked up. The pattern is, any time a new house foundation stone is laid, she would get this. Morbid jealousy. Morbid jealousy. There are 2 ladies, very nice. Okay, these are stories in this thing. This may look like this thing, but true. 2 ladies. They share everything between them. And she tells, and the husband, she tells, when we have a good night, I take bath next day. This lady has told to the neighbor. Whenever that neighbor lady takes bath, this lady knows something has happened, and she gets a bad headache. Jealousy. What to do? Sister-in-law. One of this thing, we have, Pradeep, when you were there, we had this, I think, or it was after we went there. Sister-in-law, one of the brother is in Dubai. This other lady, she fakes illness so that she can take the other sister, her co-sister, to sleep with her so that she cannot be with her husband. And when we examined this, we have a Prateek test, she falls all over. She falls all over the place. That is why knowing humanity is very, 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 to know all these things. I think you have another more scandalous story.
No scandal. Many times people will say, हमने खाना खाया और गैस सर पे चढ़ गया.
Gas sir pe chad gaya.
This gas sir pe chढ़ गया may sound very funny, but actually there is a neurogut axis,
Migraine.
and this may be a feature of migraine.
It's a migraine. Gaseousness. We have a ENT doctor. Okay. Dr. Henry. Okay. He's an avid photographer and traveler, everything he does this. He used to have this gas and then this attack. I told sir, apo jo hai wo migraine. In the beginning he didn't believe me, but he has a regard for me. I will try next time. And now he is the biggest votary of this. He tells this is all migraine. because he started treating as migraine. I tell the most common reason why somebody does an upper GI endoscopy and comes up with a APD acid peptic disease diagnosis is all migraines.
My wife is a gastroenterologist. I used to have fight with her every day. She said, gas sir pe kabhi chadta nahi hai. I said, this is not gas which is going, it is basically a migraine.
It's a migraine. Okay, lot of people you ask the story of headache, they will tell headache to nahi hai sir. लेकिन जब gas होता है तब headache. Like this. So these are different reasons how we should suspect a migraine.
And sir,
Yes.
one of the common thing in migraine patient also is when they comb, they say that there is a stress
Allodynia.
pain.
Absolutely.
And they say that whenever they have put a choti or tight,
They cannot
they,
put it tight.
they can't put it. Whenever they release it, the things are comfortable.
Okay. They cannot. The pain, allodynia happens, and then they cannot tie what Dr. Sethi is telling, that they cannot put the thing tight. Okay, they have to leave the hair loose. Okay.
These are the patients of chronic migraine.
Chronic migraine. Absolutely. Allodynia. Yes.
Or with medication use.
The-
Most of these patients.
So what sir is telling is medication overuse headaches. It has reached a stage of chronic migraine. It has reached a stage of chronic.
पेशेंट्स होते हैं बोलते हैं गैस सर पे चढ़ गई वो प्रेस करते हैं और गैस
Sir, these are all migraine.
गैस निकल रही है
गैस
जब आया गैस
तो इसका मतलब है सिर्फ सर पे चढ़ा यहाँ भी चढ़ा. Stress can be a triggering factor for migraine. Huge triggering factor. Being stressed. So we can talk about migraine for the entire day. But we need to go for the next question. The next thing about this short-lasting vertigo, there are few patients in whom the episodes can be less than 3 minutes. There are few patients in the episodes can be less than 10 minutes. There are few patients in whom the episode can be less than 1 hour. And that group is transient ischemic attacks of the posterior circulation. Previous books used to mention monosymptomatic vertigo can never be caused by a TIA. It used to be written. But now that has been rewritten. Okay, monosymptomatic vertigo. Monosymptomatic means only vertigo in the absence of a diplopia, in the absence of a dysarthria. Okay, all of these things. Can it still be a TIA is the question, in the absence of anything. Now the consensus is yes, it can be. But the savior for us is it cannot be more than 6 months. The history is more than 6 months of a monosymptomatic vertigo without anything else. Then you have a reasonable amount of certainty कि TIA नहीं. But up to 6 months, even if it is isolated vertigo, especially in a person above 50 years of age, think in terms of TIA. Okay. These people also can have falls. Achanak big spin and then they will fall. Okay, that is one more possibility. Okay, we have a falls expert here. Dr. Pradeep is there. So that you can have a fall. Okay, even falls can happen. You can diplopia, dysarthria, any of the dangerous D's comes. Then you know it was a TIA. That's it. But the problem is, in the absence of these things, when to suspect a TIA? There is one nice phenomenon that has been observed now. That phenomenon is called crescendo pattern. What is crescendo pattern is, as the time is passing in the last 1.5 months, 2-3 months, it is becoming it is becoming, as the days are passing, it is becoming more frequent and more worsen. More frequent and more worsen. So first it was like 2 weeks ago, 2 weeks के बीच में gap में आया था. अभी तो every alternate day it is coming. This crescendo pattern is very much a signature pattern of this thing. So of late, when was the story? It's at 3 months I started. Now it is becoming very bad. If the person uses the word of late, it is becoming very bad, and the entire story is less than 6 months old, think in terms of TIA. Okay. If not anything, just start ecosprin and then do all the evaluations. Okay. Ecosprin is a double-edged sword nowadays. Previously, ecosprin used to be just at the least suspicion people used to give. Now we started recognizing ecosprin has its own problems. We've had patients are taking ecosprin who's had GI bleeds and then getting admitted in ICUs. All of those things are also happening. So it is there. But there are some places where you should be thinking because you should be stopping a stroke from happening. That is in this particular group of patients in whom, even though it is a monosymptomatic vertigo. If it is non-monosymptomatic, there is not much of a differential diagnosis. But if it is a monosymptomatic vertigo, then you should start looking at terms of giving ecosprin. What if it is more than 5 years elderly gentlemen, 65 years old, 70 years old, 75 years old. Not led to a stroke anytime, but patient is having all the symptoms. Diplopia bhi hai, dysarthria bhi hai, vertigo bhi hai, sab hai. Now it is not TIA. Angiography hua hai, sab hua hai, there is no problem. There is no evidence, much evidence of stroke, because anybody has some evidence of stroke you will get, but blood vessels seem to be great, but then this person is having this kind of attacks again and again. Miller Fisher, beautiful neurologist, okay, had written a series of presentations called Migraine Accompaniments of the Elderly. Migraine Accompaniments of the Elderly. Okay, beautiful paper. Okay, so he has written descriptions. Only missing in that is the vertigo description. Every other description is there. But now we also are seeing vertigo also description. The way I treat these patients is, the beginning days I give for one about up to 10-20 days of flunarizine. After that, one flunarizine a week. Because flunarizine in that age group is very bad. Because it causes Parkinson's. It causes slowing, lot of this. But for some reason, weekly once flunarizine is helping. Weekly once flunarizine is helping. So you can consider giving flunarizine once a week and then see. A lot of people are there. Now I have a set of patients on a long follow-up with this regimen and they are under control. So this is about the short lasting and this episodic vertigo. There are so many other things that you can do about this thing. There is one chronic condition, vestibular condition, that I want to talk about now. That chronic vestibular condition is a condition called bilateral vestibular loss. Bilateral vestibular loss. What is bilateral vestibular loss is, both inner ears are not doing their work. Now comes to what is the work that the inner ear does. Inner ears from the cochlea onwards, their primary function why they emerged was localization. We think ears function is language. No, they started off as localizing. What is this localizing? A bird, when it is making sounds, what is it asking for? It is announcing its presence. I am here. The other bird which is hearing, it is hearing that presence. Where are they? My mate. When the deer is there, its ears are up and hearing. It is listening to the sounds of the predator. Where is the predator? When a bat uses it, it can map. That is next level. It can map the entire environment. Are there examples of that level, bat level of vision can be done only by hearing? There are human examples. One of that example is Ben Underwood. There are YouTube videos of him. Write it down, you can see some other time. His name is Ben, B-E-N, Ben Underwood, U-N-D-E-R-W-O-O-D. The boy died in his teens, but he had a retinal cancer. Both his eyes had to be removed, and he developed hearing using his hearing. And he developed vision using his hearing. Just echolocation. He keeps clicking, and then the echoes coming out from his environment makes him get a view of the scene as good as vision. He can play basketball, he can do cycling, he can go upstairs. He came to teach us something to the world. Unfortunately, he didn't see his 20s, but he taught something big to the world at time. Okay, Ben Underwood. You can see those videos, how he plays everything. Okay, so this is one. So this inner ear was actually made as a localizing organ. Localization of yourself with respect to where you are in the environment, localization of things around. The other part in that localizing and orienting, localization, orientation, this part. The other part actually is the utricle and saccule. The primary function of the utricle and saccule, if you go theoretically, it will return linear acceleration sensor. But the final, that linear acceleration for all practical purpose is nothing but gravity. So the actual function of utricle and saccule is to tell which is the line of gravity to a very high level of precision. A person who has lost the inner ear function in that particular area loses that precision of where is the line of gravity and therefore their complaint is not being sure-footed while walking. Not being sure-footed while walking. Every patient who comes to you with vertigo, एक question जरूरी है, especially in a person who is little older. That question is, how is your walking? Don't miss this question. How is your walking? A person with a gait disorder will immediately pick up the clue and they will tell, sir, wahi mera problem. That is my problem. When I am sitting, no problem. When I am lying down, no problem. When I stand up and walk only, I start having my problem. This particular person has a gait disorder. The vestibular diagnosis in one of those gait disorders is bilateral vestibular loss. There are other things like somatosensory loss can be there. There can be so many things. Cerebellar degenerations can be there. There can be Parkinson and Parkinson's plus syndromes which can cause gait disorders. There are conditions like normal pressure hydrocephalus, multi-infarct dementias. All of these things can cause gait disorders. But the vestibular diagnosis in the gait disorder is bilateral vestibular loss. They have a difficulty in walking. This difficulty in walking is more, they cannot even walk with their eyes closed, which tells that it is a sensory disorder. Okay, with their eyes closed, they cannot walk at all, or very difficult. That is again bilateral vestibular loss or somatosensory. That is it. Only two differential diagnoses. Now, how do you make a diagnosis in this guy? Very simple. In your clinic, you should have a foam cushion. Okay, a hard rubber foam cushion, which actually this thing somewhere about more than 60 that we call as a hardness, where spring action should be there. If the person lies on, moves on this, there should be a spring back of that foam. That kind of a foam you should buy and you should keep. Once make the person stand on the foam and close the eyes. If the person cannot stand for 5 to 10 seconds on a foam with eyes closed, you make a diagnosis by bilateral vestibular. There, what is happening? Why foam? Foam removes proprioception. On the foam, standing with eyes closed removes vision. Only if the person has good vestibular sensation, he will be able to maintain upright stance. If he cannot, if he falls, the diagnosis of bilateral vestibular loss is made in a person with predominant complaint of difficulty in walking. Yes. So as we go through, no, in the Rombox there are multiple stages. So I think we will do the examination part another 5 minutes. So the way Rombox is done is feet comfortably placed like this, eyes open. Step 1. I'll give the full interpretation. If a person walks to you nicely into your chamber without any assistance, whatever, he is telling lot of complaints. When you start doing this test at this stage and he starts shaking, 100% functional. The person was brought by assistance and all of those things, he really has a difficulty in standing up, gross muscle weakness, gross this thing, then that diagnosis. But he came nicely, everything, but the moment you want to test, you make time. This fellow is doing this, that fellow is functional. But at this stage, now this interpretation is very important. You go to the next step only if he passes the first step. There only if he is doing all these things, forget about it. There only stop, that is enough. If he passed this stage, no problem. Then bring the narrow stance. On going to especially the dynamic change into the narrow stance is making lateral instability. Okay, dynamic stage of this narrow stance is making him lateral instability. Or after that, whatever. In this narrow stance, he is having a little extra instability, cerebellar degenerations. Okay, that is the next thing. If he passes this stage and he becomes exclusively more unstable in the tandem stance, if he passes that, if he is very unstable here, in tandem also you are expecting it to be unstable even in cerebellar. But if he passes the narrow stance stage and becomes more unstable in the tandem stage, it needs a little bit of muscle strength for maintaining the tandem. This is sarcopenia or some kind of muscle or some kind of myopathy or sarcopenia, these kind of things. Sarcopenia is very common in the population, much more common than we think. Okay. Because we don't exercise and the only good food we eat is chaats and masalas and all of those things. Okay. That is our problem. And we don't like exercise. Okay. After 40, if you don't exercise, you lose bulk. It's a rule. Okay, you lose bulk. Loose bulk means by 60, then knees start showing problems. By 70, you have had a TKR. All these things are there. So best is to start exercising. The last final this thing is warning is at 40 you should have started. If you are above 40, anybody, whoever is here, and you still not started, today is the warning. Please start doing exercise. And simple exercise will not help. You need weights. Okay, you need to do weight training to be actually maintaining the bulk. Otherwise, it will not maintain the bulk. Number one, this is your insurance against problems in the old age. Okay. Nobody wants to be dependent. Today, anybody's problem is nobody. All of us know death is inevitable. All of us know. We are all ready. What we are afraid of is not death. What we are afraid of is bedridden and dependence. We don't want that. Nobody wants that. So that is how. On the escalating, this is escalating motor complexity, the way to interpret. On the escalating sensory denial, stand with eyes open, that same interpretation. After closing the eyes, if the person exclusively becomes unstable, this is proprioceptiveness. This is the classic description given by Romberg for making a diagnosis of tabes dorsalis. Okay, this is how the tabes dorsalis diagnosis used to be made those days. Okay. Nowadays, it is because of extreme B12 combined subacute combined degeneration of the spinal cord. Then we have the peripheral neuropathies. All of those things present like that. Okay. Once you see this shakiness in a person, the next logical thing that you are supposed to do is take a 128 Hz tuning fork and check the vibration sense on the interphalangeal joint of the toe. This is the interphalangeal joint of the toe. Okay, 128 Hz tuning fork. Whether the person's vibration sense is there or not there. If the vibration sense is there, then the reason for the shakiness in the eyes closed condition could be as simple a condition as sleep deprivation or being very stressed and fatigued. Okay, is that okay? Otherwise, it is a somatosensory loss. The next thing is the person stands on a foam with eyes open. Okay, with eyes open, if the person stands on a foam stable, now make the person to close these eyes. If the person exclusively falls on closing the eyes, you have made a diagnosis of bilateral vestibular illness. In a person who comes with difficulty in motion. Is that okay? In fact, in vertigo practice, there are not many examination techniques. Most of it is history, some of them are investigations, but there are some examinations. One of these is this escalating sensory denial and escalating motor complexity with a lot of interpretation, number one. Second one is what we have called it, this is a classic cranial nerve examination, but we relabeled it as 2-2-2 test. Okay, what is 2-2-2 test is two sensations, two sides of the body and two regions of the body. What is that? Fine touch sensation on this side and fine touch sensation on this side. Okay, fine touch sensation here and here. Okay, like two head is one region, body is another region. So two. Right and left, two. Next two is fine touch and temperature sensation. So fine touch sensation with a wisp of cotton, you check all things are fine, and take a tuning fork or any steel instrument which feels cold in your environment, and then touch both sides. Ask the person whether they can feel the cold or not. Now, based on that, even if one of them is wrong, there is a problem in the neuraxis. Even if one of them is wrong, okay, it is not like this thing. Then you can, based on the pattern, you can pick up where the problem is. Okay, total one side, both face, that means higher midbrain and this thing. If it is checkerboard pattern, one side body and one side face, then it is either in the pons or in the medulla, like that. Okay, upper medulla or pons. Like that, we can find out where exactly is the lesion based on this thing. This is called 2-2-2 test. So you just saw escalating sensory denial, escalating motor complexity. Then you saw 2-2-2 test. Then the other examination technique is a test called head impulse test. A test called head impulse test, which I will demonstrate. Okay. Maybe in the next session that I am going to come, I will demonstrate how to do a head impulse test and how to interpret the head impulse test, including the last one is positional test. Is positional test, and that is the most important thing. Of all these things in vertigo, you should be able to do the positional tests, and they are simple 5-minute tests. Simplest test is called McClure-Pegnini test. The name is mouthful, but what it means is simple. Make the person lie down. Lay down. Turn right. Means full body turn to right. Again lie down. full body turn to left, again lie down straight. That's all. First positional test. Second positional test is just turn the head 45 degrees, make him lie down, take the head a little below the couch. That is called example test. That's all. In vertigo, these are the most important investigations other than the general neurology and general physician level of physical examination. What is that? Pulse to lena hi hai sabko. We had a patient, a young teenager girl with falls, recurrent falls. Dr. Pradeep is here, okay, his patient. All that he did was take the pulse, racing heart rate, hyperthyroidism. He made a diagnosis, what diagnosis? The child had already gone to 3-4 people, not got a diagnosis. What is the one thing he did different? Took the pulse. So pulse, blood pressure, general neurological, final MBBS taught neurology examination and positional tests and head impulse test. These are the only exam. There is nothing called special extra test. In Romberg's what I told, escalating sensory and accelerating motor competency with their interpretations and on head impulse test. Head impulse test and positional test are the two extra things other than what is taught in neurology, other than what is taught in final year MBBS. There is no need for any shortcut. All that we need is actually going back to basics rather than anything at all. Okay, we get a lot of that. And then observing the society. So with that, I think I've covered some of these things. It was a little non-routine. I didn't go by history mein ye puchna hai, ye puchna hai, ye puchna hai, ye puchna hai. But I think we covered a few conditions so that tomorrow in day-to-day practice you get these conditions. Triggered I didn't cover because triggered again it is coming in the afternoon. We have a separate section on BPP. Is that okay? So thank you all. Thank you so much.
Now I would like to invite Dr. Pradeep Vundavalli sir to talk on essential of vestibular migraine.
Thank you, Pradeep. Thank you, Pradeep. Good morning, ladies and gentlemen. You must have heard about one forum that is called Integrated Balance Forum. I'm very happy that it has finally took its shape and into the academics after an effort of almost like 3 to 4 years. And I'm very honored to be here on the first meeting of IBF here. This is the inception meeting of IBF. And we are having one annual congress of IBF in February in Visakhapatnam at my place. So now I take this privilege forward, where in IBF we have the coordination mainly between the ENT surgeons and the neurologists. Because vertigo is not a single man show. It has to be multidisciplinary, particularly ENT and neurology community. So to bring that liaison between ENT and neurology community, we have started this integrated balance forum, where all the eminent neurologists who are doing vestibular work in India are taking a part of that, and also throughout the worldwide, from John Hopkins, from Imperial College London, Professor Bronstein, all these people, big names in vestibular science in neurology, are being a part of this forum, and we are very fortunate to have them on board. So coming on to the essentials of vestibular migraine, Dr. Srinivas sir have made my lecture little bit easier, because even I am also having a few of the things what he has told in his presentation, so that I will be skipping that part. But before taking on the stage, I would like to thank all my teachers because of whom I am here. Basically, I am a surgeon, particularly lateral scleral surgeon who operate vestibular schwannomas and microvascular decompressions for trigeminal neuralgia and hemifacial spasm. Because of one question that I faced in a forum in Europe in 2018, today I was also into the medical neuroaudiology. So have you ever seen this creature? Chameleon. Yes, click it forward. What are the two peculiar features of this creature? One is the eye, and the second one is the color. So for the next 40 minutes, we are going to deal with this kind of a disease, which can present with myriad of presentations. So we have to listen to this, and we have to see the patient or listen to the patient and also examine the patient with an open mind to come to a diagnosis of vestibular migraine. So vestibular migraine is the second most common cause of dizziness. The first being the benign paroxysmal positional vertigo. So the phenotyping, collating and researching the term vestibular migraine renders linked to its underlying biological mechanisms. Unfortunately, in the clinical practice, this etymology may not be ideal, particularly non-headache settings, as Dr. Srinivas said, where the referral reason is dizziness, vestibular tests are normal. The patient might not be having headache. And definitely you will experience an answer of no when you ask a question of do you have a headache. The patient will be saying no. And even when the final diagnosis of vestibular migraine is placed, the patient will be seeing you with a lot of skepticism. Because of which, there is a potential hindrance of complaints in the treatment. So you need to explain to the patient, probably with a better term like non-headache migraine. Therefore, the patient gets satisfied and adheres to the treatment. But still, naming vestibular migraine is necessary to avoid increasing negative predictive value of a diagnosis of psychosomatic, anxiety-related or functional neurological disorders when the presentation is atypical or upon the failure of first line of treatment of migraine. So here we stand with vestibular migraine both undiagnosed and misdiagnosed. Underdiagnosed and misdiagnosed. So the problem here is even the Barani Society classification is not up to the mark, and even the ICHD classification, ICHD3 beta version is also not up to the mark. Where they have placed in ICHD3, where they have placed vertigo as an annexure, but not in the main feature of ICHD3 classification. But ICHD3 2018 classification, they have given some importance for the vertigo. So vertigo is always, in most of the cases of migraine, you can have it as a presenting symptom. Whereas migraine can also be present in cases of vertiginous patients. So this is the Barani Society's criteria, we all know about this. At least 5 episodes lasting for 5 minutes to 72 hours. So it has seen almost like 3 days. So that means it is seeing both the sunrise and sunset, which differentiates it from Meniere's disease. This is first point. The second one is, the point B is current or previous history of migraine with or without aura according to ICHD. Third one is one or more migraine features with at least 50% of vestibular symptoms. Headache with 2 of the following features like one-sided unilateral location, pulsatile quality, moderate to severe intensity, and aggravation by routine physical activity. So this is one question you need to ask. Is your headache getting worsened with your regular activity, routine activity? Yes. Probably that is one feature you need to consider. and of course photophobia, phonophobia, visual aura. And D is not better accounted for any other vestibular disease or ICHD disease. This is the Barney Society's criteria. Barney has given one more diagnosis called as probable vestibular migraine. But whereas ICHD does not have this diagnosis of probable vestibular migraine. So how do you remember the Barney Society's criteria? One is the time duration, 5 minutes to 72 hours. Second is the history of migraine. Third one is the features of migraine. Fourth one is not accounted for other diseases. Duration, history, clinical features, and not accounted for other diseases. So rather than that, probably ICHD have come up with this classification in the newer version in 2018. This makes a little bit more sense. 5 episodes, current or past history of migraine, vestibular symptoms of moderate to severe intensity lasting between 5 minutes to 72 hours. And at least half of the episodes are associated with at least one of the following 3 migrainous features, that is headache with unilateral location, pulsating quality, moderate or severe intensity, aggravation of physical activity, photophobia, phonophobia, or visual aura. If you see, even if one episode of, if there is no headache, you can have a photophobia or phonophobia, where you can diagnose the vestibular migraine. That's what Dr. Srinivas sir already told. So coming on to the Barney Society or the criteria here, C, criteria C here is between 5 minutes to 72 hours, you can see here. So that means the duration is highly variable. It can last for seconds, it can last for minutes, it can last for hours, and it can for days. But the criteria is from 5 minutes to 72 hours, but if the patient is having the attacks only for few seconds, how do you count that? There will be pulses of these episodes of duration of seconds. 10 seconds, give a pulse, 10 seconds, 10 seconds, 10 seconds. So you have to calculate the onset of the attack to the ending of the attack. So thereby it can be coming under the zone of 5 minutes to 72 hours. And these are the patients. What is it? Yes, sir.
So in the migraine criteria, they have now included the hearing loss also.
Yes, sir.
So this become evident that in the vestibular migraine they have not included that sometimes the patient may have temporary hearing loss, which may or may not recover.
May not.
So there comes the role of migraine veneer complex.
Yes.
Right. So it is important that if the patient have mild SNHL, right, maybe 10, 15, 20 decibel, but there is asymmetric, the other ear is normal. Then to grant that patient, typically years, you have to do other tests, see the SISI and all that. So there are, I have seen 2-3 patients that were diagnosed with menias, not responding to the usual menia treatments. When we give this anti-migrainous therapy, they responded really very well, and gradually the hearing improved over the time. It does not deteriorate like in the menial disease, but typically the hearing loss is mild, sometime maybe to the moderate categories, and we have seen series of patients like this. So that's where the migraine itself connect this in this criteria. The hearing loss may happen with migraine, but then when they define vestibular migraine, they forgot to mention that it can also cause hearing loss. That was what I wanted to ask.
Yes, sir. Thanks for the input. But the hearing loss in menias and migraine most of the times will be differential. Hearing loss in menias will be in low frequency and mid frequencies will be affected, whereas in high frequency will be affected usually in vestibular migraine. There will be a high frequency loss, and probably there are few slides coming down. Usually hearing loss can be bilateral in migraine, whereas it will be unilateral in Meniere's disease. There are few slides here, and of course following my lecture, Abhik sir's lecture is there, migraine and Meniere's complex, overlap syndrome. And coming on to the Barney criteria D, at least half of the episodes associated with headache, phonophobia, photophobia, and visual aura. One symptom is sufficient during a single episode. You need not have all the symptoms. Either photophobia is sufficient, phonophobia is sufficient. Different symptoms may occur during different episodes. One time the patient might be having photophobia, the other time he might be having a phonophobia. Associated symptoms may occur before, during, or after the vestibular symptoms. So these are the detailed explanation of these criteria, what has been laid down by Bharani as well as ICHD3. So you need to keep them side by side because there is no uniform conclusion between Bharani Society and ICHD3. So you need to keep them side by side. You have to adjust them for your clinical practice. So this is a useful classification or useful explanation given by Michael von Breven, the eminent neurologist from Germany. So he is also in the associate board of Bharani Society, also in the neurological headache classification society. So in the last point, better not accounted for other disease, other vestibular disease. So you need to ask the history and physical examination which does not suggest other vestibular disorder. So key points regarding the vestibular migraine. Vestibular migraine is a frequent condition in general headache and neurology clinics. Migraine patients with vestibular symptoms may be having concomitant autonomic, inflammatory, or connective tissue conditions. Generally, migrainous patients need not have all these things, but migrainous patients with vestibular symptoms can have autonomic, inflammatory, or connective tissue conditions. So, migraine or vestibular migraine, you can consider it as a silent pandemic. Most common cause of spontaneous episodic vertigo. It accounts for 11% in specialty clinics and 1% of the normal population and 3% of adults. 60% of the patients with chronic migraine and 73% of the patients migraine with aura. Now, recurrent episodes of vertigo of unknown origin should be attributed to migraine after a thorough headache analysis. Vestibular migraine should be included in your differential diagnosis of every patient with unexplained dizziness. So vestibular migraine is one differential diagnosis of unexplained dizziness of your patient. So coming down to the pathophysiology, I won't dive much deeper into that. I will tell it very superficially. Abnormal activity in the brainstem or in the diencephalon activates the nerve endings in the extracranial and intracranial arteries of the head. So there is something called as trigeminal vascular complex and also trigeminal cervical complex. So you know the trigeminal now has multiple nuclei. The trigeminal cervical nucleus along with the cervical nerve fibers will form the TCC complex. So the TCC and the TVS, that's the trigeminal vascular system, together causes the symptoms of the migraine. So we all know that there are multiple stages of migraine. That's the one is the premonitory phase, the second one is the aura phase, and the spreading cortical depression, which is cause for the aura, and there is a headache phase. So vasospasm of internal auditory artery is usually seen in cases of vestibular migraine. This is the picture that is explaining to the pathophysiology of the vestibular migraine. I am running a little fast because this lecture was intended for almost 1.5 hours, but we are already delayed by 1 hour, so I will complete it by 40 minutes. So you can see here, this is the trigeminal cervical complex, and from here to the pathology goes to the superior salivary nucleus, and from there to the higher up. And coming on to the vestibular migraine, this video is one of the interesting video I found out in YouTube. There is one website called Migraine Summit World. In that Migraine Summit World, I found out this video by one of the presenters. Because migraine, if you think it's BPPV, it's BPPV. If you think it is triple PD, it is triple PD. If you think Meniere's disease, it is Meniere's disease. Usually these patients present with spontaneous vertigo, which in due course might turn up to positional vertigo, which in due course might run up to motion-induced dizziness, and sometimes also into the associated or sometimes progressing into visually induced vertigo. So most of the patients, yeah, that's okay. So there is, now we can call this thing vestibular migraine as a chameleonic because of the manifestations that are reported. And most of the patients, you have to listen to the patient, they do not present classically with rotatory vertigo or classical description of unsteadiness or dizziness. They will tell something, I am into something like a hole or something like that. And I am feeling like someone has kept me in a roll and rotating me. But the environment is stable for me. So there might be different descriptions, but because of a time constraint in the OPD or not understanding the disease, the clinician often rejects to take those symptoms, and because it is perplexing for the clinician. So patients may find their ailments are being dismissed. So that's the first impression of the patient where they don't stick on for the treatment, particularly in vestibular migraine. So how many of you have watched the movie The Troy? So most of you have watched. So you must have remembered this girl, Cassandra. She has predicted the downfall of Troy, but no one listened to her. I don't know, there is no sound.
Sound is not there.
Troy is still bad.
Don't ask the question if you don't want an answer.
Well, Cassandra, is there an answer?
For 10 years, the Greeks will pillage our country, attack our gates. For 10 years, they will raid the southern shores, enslave our neighbors, fatten themselves on their butcher casks, become rich with spoils, and our friends will flee here, and flee here, flee here. Until these walls are packed with broken people, and our city is filled with sorrow, our streets flooded with tears, until there will not be one of us with food to eat, water to drink, or air to breathe.
Cassandra! Enough!
The war will not be over until the curse is lifted. You all know it. Why can you not understand? Why do you not believe?
Because, child, we must not believe you. We cannot believe you.
So this is the position of the clinician when listening to the patient of a migraine. So coming on to the age, the temporal patterns may differ, may produce different phenotypes. Usually in females it will be around perimenopausal age. Of course, between 3rd decade to 6th decade, anywhere it can happen. But usually in men, it's almost all around 3rd decade. So menopause was one of the variables distinguishing vestibular migraine from other migraine phenotypes. Usually, the females who are migrainous premenopausal will turn up into vertiginous migrainous postmenopause. That is, headache is the predominant symptom premenopause, and vertigo will be then they will become vertigo as the main predominant symptom postmenopause. So this is one transition what you can see in these kind of patients. So the frequency with which the attacks can occur anytime before, during or after an attack, and also interictally, the vestibular symptoms. And one interesting thing, if you see, vestibular migraine patients mention about the pressure in the head rather than headache. They say that my head is little heavy, my entire skull, and particularly the neck, the occipital region and the neck. This is one most common presentation what we look into. So migraine was the commonest cause of combination of neck pain and vestibular symptoms. If the patient is having vestibular symptoms and is also complaining of neck pain, which the patient themselves diagnose as spondylosis. I have spondylosis, but I have these vestibular symptoms. My physician have given me a neck collar stating that it is a cervicogenic disease. but actually most of these cases are vestibular migraine. So neck stiffness is the second most common premonitory symptom reported and triggered in migraine. So please do ask for neck pain if the patient had not told about the neck pain. In patients with aura, the frequency of vertigo symptoms are doubled. So vestibular migraine patients as well as the migraine patients are more sensitive to certain stimuli like visual symptoms, stimulating the motion sickness. Like this has been discussed by Dr. Srinivas in detail earlier. So what are the other comorbid conditions? These things will give you a good clue. Migraineurs have high probability of having other vertiginous conditions like BPPV and motion sickness. Migraineurs have higher risk to develop ear problems like tinnitus and hearing loss, leading to misdiagnosis even in the specialty clinics. So this is what Amit K. Srishar has been telling about. So triple PD patients parallel migraine in multimodal hypersensitivity, altered functional connectivity between the thalamic, visual, vestibular, limbic and cerebellar regions, causing excessive visual or postural stimuli dependence. In both these patients, there will be excessive dependence on visual and postural stimuli. So most of the cases of chronic migraine, one may misinterpret the daily or persistent symptoms for those of triple PD, because if these vestibular migraine patients with a due course, they complain consistent dizziness throughout the year. So we think that, probably this patient might have landed up in triple PD. But still it's vestibular migraine and it responds for your migrainous therapy. So it is very difficult for the patients who are having triple PD or vestibular migraine as these presenting symptoms of chronic dizziness that is continuing throughout the year. And because of the chronic neurovisceral dysfunction, the vertigo or dizziness can be associated with asthma, bladder problems, sleep disturbances, rhinitis, tachycardia, GI disturbances and memory problems. So this is what Dr. Srinivas have told earlier, gastritis with migraine, even allergic rhinitis with migraine. So for that, this is a mnemonic that need to be remembered. The comorbid conditions that can be associated with the migraine. The migraine can be associated with autonomic problems like POTS, orthostatic hypotension, syncope. Classical migraine symptoms like photophobia, phonophobia, osmophobia, allodynia. Any inflammatory disease like asthma, rhinitis, allergies, or even thyroid disease. GI symptoms like reflux, gastroesophageal reflux, the gastritis, and irritable bowel syndrome. The patient might be having irritable bowel syndrome and migraine. The uterine conditions like endometriosis, polyps, myomas, and even there might be a history of hysterectomy. See, they might be telling, after my hysterectomy, all these symptoms started. So then again think of migraine. Incontinence, the hyperactive bladder or frequent cystitis. The tissue disorders like hypermobility, the Ehlers-Danlos syndrome, rheumatoid arthritis, SLE and Sjogren syndrome. Fibromyalgias, chronic back pain, chest pain, and skin problems like urticaria, psoriasis, eczema, rashes. What not? Which system is not involved here? All the systems are involved. So these are the associated comorbid conditions, and patients usually stress upon these conditions. They will be insisting on these conditions. So that means vestibular migraine is associated with any of these conditions. So migraineurs with dizziness have a relationship with dysautonomia, hypermobility syndromes, or mast cell activation syndromes. So this justifies the antihistaminics like loratadine and cetirizine are effective. The patient comes to me for allergic rhinitis thinking that I don't deal with migraine. When I treat him with an anti-allergic, desloratadine with montelukast. After a few days, after 3 weeks or 4 weeks, the patient comes back, sir, my allergic symptoms are very good. But apart from that, Earlier I used to have headaches and some dizziness, now that is gone. So even your loratadine or cetirizine can also help in alleviating the symptoms. So what are the investigations we do? I think you can stop me whenever you require. Neuroimaging, audiovestibular test, VNG or EEG. Currently we are doing one study, the stimulation of the supraorbital nerve, the changes what we get in median nystagmography in migraineurs. So what are the markers? Can we have some markers in migraine? Usually insulin levels are on the higher side. You can measure serum insulin levels. So the migraineurs with increased oxidative stress can develop deep white matter hyperintensities like this in picture. In MRI you can find these deep white matter intensities. Superoxide dismutase, you can find the levels to be reduced in migraineurs. None of them are pathognomonic of migraine, but these are the markers that you can have. In chronic migraineurs, you will be having a cutaneous allodynia, and so this is a functional MRI during the migraine attack. You can see the areas. This was taken from the paper of Michael von Driven from the German University. So coming on to the core vestibular testing in vestibular migraine. So there are two phases in a vestibular migraine. It is ictal phase and interictal phase. There will be different features in ictal phase and interictal phase. In interictal phase, the most common presenting finding is unilateral reduced caloric responses. So please do a cold calorie test for all the patients. Even though it is disgusting for the patient, even though it is very uncomfortable for the patient, please do this. Reduced unilateral caloric response is the most consistent VNG finding that you can find in interictal state. And one more suggestion for all the youngsters, particularly from ENT, don't label vestibular migraine diagnosis in the first visit itself. You have to see the patient at least 3 to 4 times, ictal phase, interictal phase, every time. And if you check the same patient during the ictal phase, that is during the active attack of headache or active attack of vertigo, then if you do a cold calorie test, if the patient permits for you, then the cold calorie test is normal. If you compare it with earlier in the interictal phase where the response has been reduced, now it is normal. That is, you can say it as fluctuating caloric responses.
Can be years.
You have to correlate with other features. Can be many years, but this is most common but not classical of migraine. And one more important thing is, while you are doing cold calorie test, these vestibular migraine patients are more emetic. Here you can differentiate between Meniere's disease and
Calorie tolerance.
if you do caloric test in migraine patients, they are not emetic. But if you do